Hello everyone. So today we are going to discuss another very important and high-yield topic, which is tiredness. I'm mainly going to discuss the differential diagnosis of tiredness because there are so many differential diagnoses for this symptom and they are all very important. I will also briefly describe the management, but for the management, I will make another detailed video. So in this video, we are just going to focus on the differential diagnosis and what to rule out, what are the red flags, and what to safety net for. Okay, so the main differential diagnoses that we have for tiredness are six. There are six main differential diagnoses here, but in any station, when you do OD-para for the tiredness, because a patient will tell you that doctor, I'm feeling very fatigued or I'm feeling very tired. So naturally, you will ask him, can you please tell me a bit more about it? So he will tell you two to three sentences about his tiredness, and then you will do the OD-para. So while doing OD-para, you will get some clue that where the patient is leading you. So after that, you do not need to go through all the six differentials, just at maximum do four differentials, but there's for every symptom, there is always one or two differentials that you need to keep constant. There are basically the red flags that you have to rule out no matter what. Okay. So the first differential for tiredness is anemia, which is the most common one as well. So here, the patient will have, along with fatigue, the patient will complain of dizziness, the patient will complain of heart racing. There may be some history of blood loss from the body, blood loss in the stool, or maybe diarrhea, or there may be history of, poor dietary habits. So iron deficiency anemia, okay, or it may be vitamin B12 deficiency anemia because of diarrhea or because of any surgery on the stomach or because of pernicious anemia. Okay, then the next differential that we have is apnea, which is basically obstructive sleep apnea. This is also a very common presentation with tiredness. So the patient here basically present with tiredness, and when you probe the patient further, asking for differentials, when you ask the patient, so how is your sleep? Because when the patient tell you that I am tired, so the first thing that comes to your mind is this person sleeping enough? So you will ask him, how is your sleep, by the way? And he will say that, my wife complains or my husband complains that I snore a lot and sometimes I wake up in the middle of the night. So this will be your classic presentation of obstructive sleep apnea. Patient will tell you that he snores, he sometimes wake up at night, and he feel very sleepy during the day, and he might be napping during the day. Okay, so this is obstructive sleep apnea. The next thing that is basically red flag for tiredness is cancer. So in every in every patient with tiredness, you need to rule out cancer. Now, what are the symptoms of cancers? I already told you in a previous video that we rule out flaws for cancer, which is fever, um, fever, lumps and bumps in the body, appetite loss, weight loss, and night sweats. Okay, so flaws is basically a mnemonic which stands for fever, lumps and bumps in the body, appetite loss, weight loss, and night sweats. So this is the red flag here that you need to rule out and that you need to safety net for. Okay. The third differential that we have is diabetes mellitus. So in diabetes mellitus, the patient will again present with fatigue and tiredness. And along with that symptoms, there will be polyuria and polydipsia. Then depression, another very common cause of tiredness, the patient will present with low mood. Okay, and the other classic symptoms of depression like irritability and loss of interest in the previous hobbies and stuff like that. Endocrine, the fourth one is endocrine and electrolytes. So endocrine problems like hypothyroidism. And hypothyroidism, what will you get? The patient will complain of weight gain and constipation and tiredness. And the patient will say that I feel cold when everybody is feeling normal. And then electrolytes, so hyponatremia and electrolyte disturbances can cause tiredness. And the most common cause of electrolyte disturbances are usually either nausea and vomiting, but they are very short-lived. So for long-lived causes of electrolyte disturbance, there are things like syndrome of inappropriate secretion and medicines, for example, steroids, citalopram. So you need to ask the patient whether are you taking any regular medication. So electrolyte imbalance can be a cause of tiredness. Then we have chronic fatigue syndrome, but actually I would like to keep chronic fatigue syndrome at the end. Before that, we will discuss HIV. So HIV, as you all know, is a viral infection, and sometimes the first presentation of HIV is also tiredness. So in tiredness patient, if you feel like the patient can have HIV, then you will take the detailed sexual history and the history of drug abuse as well, whether the patient shared needles at all and stuff like that. The chronic fatigue syndrome, I want to keep it at the end because this is basically a diagnosis of exclusion. So here the patient is just feeling tired and the tiredness is out of proportion to the activities, and he sleeps a lot, doesn't feel really refreshed after sleeping, and everything else is negative. There is no other symptom except from fatigue. Maybe the patient give you history of, if it's a very typical case, the patient may give a history of viral infection or flu-like illness 6 to 7 weeks before the onset of feeling tired. So these are basically differential for tiredness. Some people can also classify, try to memorize it with a mnemonic, which is A, B, C, D, E. So basically skip B, and A is anemia and apnea. Then we skip B, C is cancer, then diabetes mellitus and depression. Then E is endocrine and electrolyte, and then H is HIV. And chronic fatigue syndrome is a diagnosis of exclusion. All right. Another important thing that you need to remember in case of tiredness is to ask about the psychosocial of the patient. So take a good history about the psychosocial of the patient, because tiredness is not an acute case. The patient does not come to you and says, Doctor, I've been feeling tired for the past couple of days. It's always a history of months, or at least it's a history of 4 weeks or 8 weeks or something like that. So it's always a really long history. So when a person is feeling so much tired for such a long time, you need to ask about his job and how is he coping at work. Is he able to do activities of daily living? Is there some support with him? And how is it affecting his mood? Okay, because feeling tiredness all the time, all day long, for such a long time can cause depression as well. Depression is a trigger for tiredness, a cause of tiredness, but feeling tired due to other reason can also trigger depression. So these are very closely correlated. So you need to keep an eye for it. All right, management I will discuss in a separate video because then the video become very prolonged. The management for all of this is very detailed. So I'll see you next time with the management for tiredness.